Dear Chairman, thank you very much for the invitation. Dear ladies and gentlemen, I want to give you a clinical picture of the potential benefit of hyperthermia in rectal cancer. And first of all, I want to ask the question, is there any benefit of hyperthermia? You all know there's a lot of discussion about hyperthermia. Does it work or not? You've seen minutes ago, it's good in soft tissue sarcoma. Is there any benefit in rectal cancer? And first of all, I want to summarize the important data to get an idea what we can do with the hyperthermia in rectal cancer. And first of all, I want to show you a Cochrane database review from 2009. This is, in my view, very interesting. So we have 6 randomized trials with more than 500 patients. All the trials were randomized radiotherapy with and without additional hyperthermia during radiotherapy. And what was found is there was a transient overall survival benefit after 2 years that vanished after 5 years. So it was not persisting, and but there was a 2.7 or 6 times higher clinical response rate. There was a much higher response with hyperthermia. So you can see in the bottom line in red, there was 51 complete responses with hyperthermia and 19 in the group with radiotherapy alone. So keep this in mind. Maybe hyperthermia can improve response rates. And there was another randomized trial done in Berlin mainly, which was a neoadjuvant 5FU-based radiochemotherapy trial combined with or without deep regional hyperthermia. There were 137 patients. Then after the neoadjuvant treatment, they received surgery and then consolidation chemotherapy. And there's not much published about this trial, but there is published that the response rate, which means in this case complete and partial response, was significantly higher in the experimental group with additional deep regional hyperthermia. And there was another trial for neoadjuvant chemoradiation 5FU based from Tübingen, which is a German country, a German city. And 78 patients were included with a follow-up of 54 months. They found a pathologically confirmed remission rate of 14% and a DWARAC tumor regression grade of 3, which means only some scattered vital cells in the specimen, or the DWARAC tumor regression grading 4 means no vital cells at all. And this rate was 50%. And they've, in this phase 2 trial, said there were promising long-term oncological outcomes. But this is important, again, they found a higher thermal dose associated with a better response rate. So we've seen now one meta-analysis, 2 phase 2 trials that all showed that hyperthermia, additional hyperthermia, improved some kind of response. And we made a phase 2 trial as well, published in 2021, and we included T4 N0 rectal cancer, advanced rectal cancer, with any kind of nodal involvement, and oligometastasis was allowed. And we included in the same trial locally recurrent rectal cancer, any if pre-irradiated or not. And the primary endpoints were the feasibility rate, because this trial had to prove that the combination of an chemoradiation trial together with hyperthermia is safe, and the feasibility rate should be more than 70%. And a secondary endpoint was to get a higher PCR rate of about 20%, which was quite higher compared to the historical data. This was the flowchart. This was a 5FU continuous infusion in the first, second, the fourth, and fifth week, combined with oxaliplatin bolus 4 times, 2 times a week hyperthermia, and conventionally fractionated radiotherapy up to 45 to 55.4 grays, quite standard. And here are the results. First of all, the feasibility. So you can see the dose-limiting toxicities, and we had a 2-stage design according to Simon. And look at the right lower corner, and there you can see the feasibility rates. In the end, it was 73 feasibility rate, which was higher than 70. There was some toxicity. This is in the picture beside, but this is quite as usual for a chemoradiation trial involving oxaliplatin and 5FU. We found no special dose-limiting toxicity related to hyperthermia, and in this table you can see only 2 patients stopped hyperthermia, and this was calculated as a dose-limiting toxicity, but it was not a toxicity, it was the wish of the patient. We included 111 patients, and 89 had a locally advanced rectal cancer, and 16 had a locally recurrent rectal cancer, and the PCR rate in both arms was 19%, and this was covered by the confidence interval that our statistician said this is a positive trial in this endpoint. And the DWARAC tumor regression grading 3 and 4 was 72% in locally advanced rectal cancer and 50% in locally recurrent rectal cancer. And here are some Kaplan-Meier curves. You can see, of course, that locally advanced rectal cancer was better in local recurrence than recurrent rectal cancer, but the data is not so bad for local recurrent rectal cancer, what was regarded 15 years ago as a palliative situation. So there's a curative potential. And if now we are looking at the locally recurrent rectal cancer patients, the 16th, if you analyze if they received surgery or not, you can see if they received surgery, it's much better, and there's a curative potential. So we need neoadjuvant treatment for locally recurrent rectal cancer that reaches surgery, R0, complete surgery, and then there's a curative potential. And in this situation, hyperthermia is a very good contributor. So what's about the future? These were finished trials. What can we do in the future with hyperthermia? And in the Atzelsberg Circle, which is a study meeting happening every 3 months or 6 months in a town near Erlangen in Germany, we are meeting and discussing new trials. We are now discussing about a new trial in rectal cancer. And what should this trial look like? We discussed this with the insurances in Germany, and they said, oh, the standard for this ugly rectal cancers, primary rectal cancers, this is the Rapid trial. And in the Rapid trial, you know this, maybe there was in the experimental arm a short course radiotherapy followed by a consolidation chemotherapy followed by surgery. And in the standard arm, there was a conventional chemoradiation capecitabine-based radiochemotherapy, and then surgery, and then optional any consolidation chemotherapy. And in this trial, which is published, they found a pathological complete remission rate of around 30%. And so the insurance has said to us, this is the standard, so you do not need any hyperthermia. And from this on, we are thinking of a trial. So if you use hyperthermia in that kind of trial, you have to be better than the Rapid trial. And this is what we are planning at the moment. Here you can see in the upper part 2 arms. You can see chemoradiation, conventionally fractionated 5 times a week, combined with 2 times hyperthermia per week, like in the HIREC trial, combined with a consolidation chemotherapy, like in the Rapid trial, versus the same without any hyperthermia, and in the standard arm, a short course radiotherapy arm is allowed by choice. So this is then, after this total neoadjuvant treatment, a re-evaluation is planned, and if there's a clinical complete remission, the patient goes to follow-up. And not if there's a near clinical complete remission, there will be a re-evaluation after 3 months. And the primary endpoint of this trial is a sustained clinical complete response rate after 2 years, or logically confirmed complete remission rate after surgery, and the rate should be, by the addition of hyperthermia, elevated from 30 to 45%. And we calculated that we are needing 440 patients, and we are working on that. Centers from Switzerland and from Germany at the moment, and this is just the protocol is nearly finished. This is my last slide. This is the summary for locally advanced rectal cancer. I wanted to show you that additional hyperthermia may improve the organ preservation rate, and to prove this, we are working on a randomized trial at the moment, and of course, contributing centers are welcome to participate. And for locally recurrent rectal cancer, patients should get a second curative chance, and we see additive hyperthermia as part of this neoadjuvant treatment to reach a better curative chance in all these patients. And this is, at our center, this is a standard treatment which is covered by the insurances. Thank you very much for your attention.
Thank you very much for this very interesting talk. Is there one very short question? Because we are already a bit over time.
There's some technical question. What is the method of hyperthermia that you use? How you localize the fields? And why twice time hyperthermia and not every day?
I'm sorry, I did not get it.
I ask about technical questions. The method of hyperthermia.
Yeah.
Second, how you localize the field of hyperthermia. How you localize? In rectal, for example. And why twice time hyperthermia during the week?
We use annular array system for hyperthermia and do phantom measurements, and then we know where the focus of this hyperthermia device is, and we have an MRI system as well for non-invasive thermometry, and we are using that kind of hyperthermia, and of course we are using thermometry probes in the rectum, if it's open, in the bladder, in the anal rim, and in the vagina, to get an idea if the temperature is reaching the tumor area.
That means you have some planning before treatment. You're doing some planning of the treatment. Planning.
We have a pre-planning system. Sometimes we use this because it's a quite complicated tool, and our physicists usually prepare planning for that special patient I'm the physician. Please do not ask me what he does.
So maybe we can delay these questions to the discussion at the end. Thank you very much again.